Hello, this is David Ford, the Executive Director of CalHIPSO. I want to thank everyone for making time to join us this morning. I guess it's now noon, and join us for your lunchtime on the November edition of the CalHIPSO monthly webinar series. We always like to start, because we get a lot of people on these webinars who may not be as familiar with CalHIPSO. So we do always like to start with just a brief introduction of who we are. So CalHIPSO was founded in 2010 by the confluence of three of the largest healthcare trade associations in California: the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. Originally, CalHIPSO was founded and built to be the federally designated regional extension center, or REC, in California. And in that role, CalHIPSO has helped providers to navigate the world of electronic health record adoption and use. And under the REC, CalHIPSO's real goal and purpose was to help providers to achieve meaningful use and to access the federal electronic health record incentive program. And over the last now 10 years, CalHIPSO has helped just a little over 15,000 unique clinicians in every county in the state, spanning more than 1,400 provider organizations. And providers working with CalHIPSO have earned just a little bit more than $300 million in federal incentive dollars across various programs. But today, we are very happy to be joined by our colleagues from Maximum Management Healthcare Services, Carium, and importantly, Gardner Health Services. And they will be talking to us about patient engagement, which is a growing and very important part of our world. And one thing I almost forgot to mention, but right now everyone who is listening is on mute. We get too many people in here to open up the lines, but there is a Q&A portion. So if you can please type your questions into the question box, which you should see on the right side of your screen. And if we have a little time at the end of the broadcast, we'll try to go through the most asked questions. If we don't get to your question, by all means, feel free to email us after the presentation at info@calhipso.org, and we'll try to follow up with you afterwards. And just to answer the number one question that we always get on every webinar, yes, the slides will be available at the end of the presentation. We also are recording this presentation, so you will be able to watch it afterwards on the CalHIPSO YouTube channel. So, with that lead-in, I would like to pass off to our first presenter for today. So I'd like to introduce Jaspreet Sodhi from Maximum Management Healthcare Services. Jaspreet, take it away.
Okay, great. Thank you. So Lauren, you're going to just pass on the slides to me?
Yes, you should have keyboard and mouse control, and you should have control of the PowerPoint.
Okay, so, well, thank you everybody for joining. We truly appreciate it. And thank you, David, for inviting us to do this presentation. And like David is talking about the fact that more and more it is really becoming important for us to engage our patients specifically around chronic disease management. And when the patient is there, they are within the four walls of our organization, either it be a health center, either it be a clinic, either it be a doctor's office, or any different type of healthcare system. And the minute the patient walks out, sort of we have those barriers of compliance and of engaging them. So one of our key focus items today as part of our presentation, which is Gardner Health Services, a community health center out of San Jose. and Carium, a technology-enabled organizations coming together to really present around engaging patients and improving outcomes with technology. So that's sort of the subject matter of our conversation today. So just to start the agenda, and then I'm going to pass it on to the medical director of Gardner Family Health Services, as well as Carium, the president, Mike, who is also on the phone. We'll go ahead and start with those introductions. Then we will go into Gardner Health Services motivations for changing how they engage patients. Definitely, I know you guys have an idea around why those motivations are there. Our focus is good patient outcomes. Some of the program objectives, why now? And I think we all know that we are going through the healthcare reform, and there's just so much engagement from the health plans, from federal requirements and state requirements that we all have to abide by, and how this program has been planned in regards to kickstarting it at Gardner Health Services. Please do note the name of Gardner Health Services just recently changed from Gardner Family Health Services to Gardner Health Services. So I might just switch around the name of the organization, but it is a federally qualified health center in San Jose. So these are the people that are on the line today. Like I mentioned, we have Dr. Ranjani Chandramuli. She's the medical director of Gardner Family Health Services. Mike Hatfield, he's the chairman and co-founder of Carium. And myself, who is sort of the facilitator throughout these conversations. I, as Jaspreet, I'm the CEO of Macman Management Healthcare Services, personally work very collaboratively with Gardner Health Services as well as Mike to really get this QI initiative going and really engaging and utilizing the technology that is accessible to for us today. Just to give you a debrief of what Gardner Health Services is, it's a federally qualified health center in San Jose, serving about 55,000 Santa Clara County residents. And it does provide a huge array of services, including medical, dental, vision, pharmacy, chiropractic services, and some of our counseling and substance abuse services as well. And you can see on the slide that's one of their mobile clinic, one of their health centers where actually the program is getting kickstarted now. This is about Carium and who they are. Exciting news, they are out of California. That helps us a lot. They are a purpose team-built organization. They provide patients and providers facing mobile and web app built on a cloud-based platform. So they basically are a technology-enabled organization with their heart and vision around patient outcomes and how to basically minimize the gap between patients and their providers. Collaborative platforms that they have in which they connect real-time the patient and the provider, and the goal is throughout their lifetime as patients are struggling through chronic disease management. So with that, why don't I first pass it on to Dr. Chandramuli, who is on the line. So Lauren, if you can please go ahead and pass on the slides to her, and we will start with the very major slide, which is the motivation of why we want to engage our patients in technology-enabled environment to really focus on their patient outcomes.
Okay. All right. Yeah. So sorry. Keyboard control.
I have the control?
Yes, you should have full control now.
Okay. I might need some help to move to the next slide though.
So Dr. Chandramuli, when you will just hit click on the slide, it will automatically go to the second slide.
Okay, great. Okay. So hello everybody. I am Dr. Chandramuli. I'm the medical director for Gardner Health Services. And one of our big project objectives for this is it's a nationwide problem that everybody is acutely aware of, how to improve the health of patients with diabetes. And our primary focus is going to be on the poorly controlled diabetes. And those are the ones that are the most challenging group of patients we have for various number of reasons. And we are trying to utilize Carium services to see how we can improve the health outcomes for these patients. And one of the main reasons why we were in contact with Carium was to leverage the technology so that we can expand the care beyond our physical clinic, because as you're all very well aware that the clinics are open only for X number of hours in the day. And what happens to the patients beyond our appointment times is something that we have no control over, and what they do with their health after they get seen or before they get seen by the clinician. So this will basically, we are trying to enable a continuous relationship with technology that helps with caring for their plan and this in conjunction with a care team model, which will help our patients tremendously. We want to make sure that we have a team at Gardner that is designated for the monitoring and for tracking all the goals and expectations for the patients. And we work with Carium based on this continuous relationship and the technology that we are going to be utilizing from them. One of the things that we want to make sure is, as I mentioned, tracking, goal setting, and all that stuff too. So here we have why now? I mean, this is an ideal opportunity for us to improvise and to create some innovative technology methods for improving health outcomes for our patients. We have so far relied on just our EMR, given the community health clinic capacities. We don't have a lot of ancillary help. We don't have a lot of case managers that can help with providing the ongoing care for our patients. So we decided as an organization that we would leverage with this new technology with Carium, and will expand this impact beyond our physical location. And this, we want to make sure that this is real-time testing and also some amount of non-real time, because we would like to collect some data for the patients and make sure that we are heading in the right direction. Our focus has, of course, been to improve patients with type 2 diabetes. As you all know, that nationwide this is becoming an issue, and we want to make sure that we focus on the something is happening here. Okay, yeah, we want to focus on patient population that is in need of additional services. Also, the main drive for this has been our priority measure for improving the outcomes for diabetes. And as always, we are monitored and by several measures. One of the big ones is the HRSA measures that we have to comply with, and HEDIS measures that have been identified as, and both of them have put a lot of pressure on a lot of organizations to make sure that we reduce significantly the number of uncontrolled type 2 diabetes. And with all this in plan, we have now made sure that we are doing this pilot program with Carium, and we are very excited to launch this thing. One of the elements of the program, some of the elements of this program is like, we selected patients from our different clinic sites, and we also have a designated coach from Gardner that will be working closely and be one of our point of contact persons with Carium, and using the Carium software platform. One of the requirements, of course, for this is for our patients to have web access and a smartphone access. And we have patients that speak both in English and Spanish, and with Carium's help, we have been able to develop most of our scripts and translations in both the languages. And of course, the devices can be either an Android or an iPhone, as the case may be. And the glucometer can be either Bluetooth enabled or a manual part of it. How this is going to be working is the patient uses a smartphone to collect their blood sugar readings and or other data, and all that data will be shared with a coach via the Carium platform. So this will enable the coach and the patient to communicate with each other by in-app messaging, so which will be real-time and immediate response from the patients. Additional capabilities of this will include the educational material part of it, and also the things that they need to be doing or not to be doing, which includes diet, exercise, nutrition, all that stuff. And also with goal setting for each of our patients, because everybody needs to have some goals that they can achieve with. And I would love to, at this point, transfer the main part of the project to the Carium team, and they will be able to guide you with the rest of the program and see how it works from their end.
Thank you,
and I'll
Dr.
be happy to
Chandramani.
answer any questions at the end of it.
Thank you, Dr. Chandramani. This is Mike Hatfield with Carium. And so what you heard is a clear articulation of what the challenges are for Gardner and what Dr. Chandramani leads in her role there. And what we're trying to do is to enable this care outside of the walls of the clinic. So what I thought we'd do was kind of talk about an example scenario. These are fictitious people, but you get a sense for how this would work then. So on the left here, you've got Ellie, who is a patient with diabetes, and then Anna, who's a member of the care team and serves as the coach. So what it looks like then, on the left is a smartphone, could be an Android or an iPhone, as Dr. Chandramani mentioned. And Ellie then has on her phone the Carium app, and it has different information that's relevant to her, and then a series of information that she can input. So one of the things that we do is we let the person say how they're feeling each day and keep track of that so they can share that information. And then on the right, you see what would Anna's view, and Anna being the coach or team member, she's had all the different people who are involved in that she's helping. You see the summary of that, and there's certain stats there that she can see in real time in terms of how each of those people are functioning. So the web view for Anna as the care team, and then the smartphone view for Ellie. Now, what you have is you enroll Ellie in this diabetes program. So she's going to get a message saying, hey, you've been enrolled from the health center into this diabetes program. You see at the top, before it had talked about blood pressure, now it's talking about diabetes. So once she's enrolled in this diabetes program, she's got specific content that now is relevant for her that shows up on her phone. And then she can click on that information, and you can see on the far right there a link to a detailed information about diabetes. So this education, oftentimes what happens in the clinical setting is someone's been diagnosed with diabetes, and there's a whole packet of information that's really great that gets sent with the person, but then do they really have access to it in a ready form? This information is always there and ready to be accessed when the patient's ready to have that. Now next, what you see is a reminder. So now that she's a part of this program, she gets a reminder that says, make sure to record your blood sugar. And as Dr. Chandramani mentioned, there are two different ways you can do it. The person could have a traditional manual glucometer where they get a readout from it, and they could manually enter it. Also, increasingly, these connected devices with Bluetooth are very convenient. And the price of those are very reasonable. You can get a Bluetooth connected glucometer for $12 now, so it's really moved the price down to being much more economical, and that would just automatically push the readings in as the person took that. So now what you're going to see here is just a scenario where, let's say Ellie put in a very low sugar reading, 63. What will happen is the system will recognize that, and then on the third one over, you see that there's a low sugar message. I'll come to Ellie and say, hey, your blood sugar is low. You should eat something. Check your blood sugar again in 15 minutes. It also lets her tap here. And so in the fourth slide, you can see this is information about low blood sugar. So instead of this big packet of information she may have received, months ago when she was in the clinic, now she's had this event happen. She's got the ability to get that information relative to her particular situation right now, and we're finding that that's much more relevant for people when it's in the moment that they're learning this information. Now the next one is, we'll go with an example where she's putting in a very high reading, so it's 400, for example. Now in this case, the system's been instrumented for this particular care model that when a very high reading comes in, that information is shared not only with Ellie saying, hey, your sugar's level's high, but also then back to the care team. Anna now sees a to-do in her list around Ellie. And what that says is that she's got a high reading from Ellie. That's over 200. You can pick, with our system it's configured, so you can pick what level you would want to have that alert. But now the care team is aware that she's had this. And then what Anna can do is come in and look at this. And so what she now sees is she sees Anna's information that's been collected over time. She can look at that chart and see, oh, Anna's actually been in very good control for quite a while here. This is just a spike, but let's keep track of it. Versus, if it had been very high over a long period of time, it's a different kind of context, and she can quickly see sort of what's happening in her view. So now she's got this information. She knows that this has happened with Ellie. She now can go into the secure HIPAA compliant messaging and start a dialogue with Ellie. And again, this is all things that maybe 3 months down the road in a traditional diabetes management perspective, there'd be a conversation about the fact that Ellie's reading was high, but it wouldn't be in the moment. Now it's right in the moment when this is all happening. Anna can send this note to Ellie and message to her saying, hey, I saw this. And this shows an example kind of back and forthing then that can happen where it said, hey, I saw you had that high reading, everything okay? And Anna, Ellie is describing that she's had trouble staying on her meds. And so there's a whole conversation here, including, hey, let's put together a plan here. And so what the system allows Anna to do is put together a to-do for Ellie. They collectively say, hey, let's do this. And so now there's a reminder that comes in for her to journal her meals and her exercise so that you can kind of put her on a path of ways to take better control of what's happening. And that now is something that they've collectively decided to go do together to help Ellie with her challenges. And then we also have journaling. So that was part of the shared agreement that they had between Anna and Ellie. So now Ellie's now taking a picture of a meal she's had recently. She's very proud of the fact that she's on track with her eating, and she sends that to Anna. As you can see in the right there's a picture that she's shared, and so this can be used in various different ways in terms of if someone's really having trouble with their eating, they can be sharing these photos and just take a picture. Instead of having to journal every little item that someone ate, just take a picture of what their plate is, and there can be an education around what's being eaten and encourage change. And then what we also can do is actually put together goals. So this is again a shared goal setting. So what you see here on the left is Ellie's got these goals that they've come up together with Anna. And so her objective is to walk 5,000 steps 4 times a week. So you can see the 4 checks there represent the number of times a week that would happen. And then in this case, the blue checks represent that she's done it twice for this week already. Likewise, measure her blood sugar every single day. So she's been doing great with that. She's done 5 out of the 7 for the week. And then another particular goal in this case is just don't drink soda 5 times a week. And it may seem counterintuitive, but I think we all know that this can be a tough thing for people, even though they know they shouldn't be drinking soda at all, to get on a path of avoiding that and having that something that okay, I'm going to do it for 5 days this week. I have 2 days where I can still drink it, but 5 days I'm going to do that, and just help people get on this path. And those goals, not only is Ellie tracking them and keeping a view of them, that's also shared back with Anna, so Anna can see how Ellie's doing on her progress. So the other thing that's important in this, and this sort of gives a scenario, is on the recruitment side, and this is something we've been very focused on with with the team at Gardner and Dr. Chandramuli. And one of the things about this is because it is such a new mode, you really want to focus on who's a part of this cohort. So the participants are going to be really focused on majority are going to come from their St. James locations in San Jose, targeting type 2 diabetes with an A1C of 10 or greater and an age group in 45 to 60. The participants must have a smartphone, and then we support both English and Spanish. And what you see over here on the right is the kind of materials that are helpful because this is a new mode of care. We found that it's really helpful to share that information, and particularly if one of the clinicians has the conversation with the person, having this information to explain what's going on and how it works. And as you can see, we do it both in English and Spanish, has been extremely helpful to share that information with the potential participants.
So Mike, can I just quickly sort of say something? This is just Preet again on the line. So I think, there has been internal work that has been happening at Gardner Health Services in regards to chronic disease management, in regards to diabetes. And we know there's just so much comorbid conditions that are related to diabetes management. So there has been a lot of work that has been happening internally within the four walls of the clinic when the patients are coming in. And we know that by the time you will see the patient next is about in 3 months. And at that time also we have challenges around making sure that the hemoglobin A1Cs are done, to monitor the patient's progress and everything. So this technology sort of gives you going outside the clinics. I think that's one of the key elements we are talking about. And when we are talking about the recruitment, because this is our phase 1 of the cohort, we decided, looking at the data that we have from Gardner, which area to start first, where would it be better to recruit patients from. So looking at your patient population. Also in regards to the fact where you will see a little bit more higher compliance rate. So a lot of those elements are part of this project. And as we are doing the recruitment, our maximum number of patients that we would like to get into this first cohort is 50 patients. So at least having a number of up to 50 patients, it could be less than 50 patients, would give us enough data as the project moves forward so that we can look at what works and what doesn't work. Because our goal is eventually to, again, phase this out so that eventually we can have enough data to maybe implement this program throughout the organization. But that sample, random sample of patients within this criteria that we are looking for is up to 50 patients, and we are hoping that's what we will achieve.
Right. And I would also like to add, thank you, Jaspreet, for that scenario, because that's exactly what we're looking at too. And one of the main things that we also wanted to look at is choosing which kind of patients might fit into this pilot to make it worthwhile and to be able to collect some data for us that would be useful. And that's one of the reasons why we chose the age group of 45 to 60. And also we wanted to make sure that the participants have a smartphone and have a little bit of tech savvy knowledge so that they'll be able to use the smartphone the way it's supposed to be used. And that's one of the big reasons why we chose that age group, because they probably are the more tech savvy population that we can, more than the geriatric population.
Thank you. Okay, Mike, I think you can take it back.
Great. So this is a quote, and Dr. Chandramuli, you can share sort of your thinking around what this means for you.
Dr. Chandramuli, are you still there?
Yes, I'm here.
Okay, the last slide, I think one of the last slides that Mike wanted you to sort of give a little bit idea of sort of why is Gardner really doing this?
Like I said in that quote that I have, people we serve have many challenges and in their everyday life. And we deal with probably 40 to 60% of the uninsured that are 200% below poverty level. And basically, they are literally looking to find means to even supply 2 to 3 meals a day, if anything. We are looking at a huge number that are homeless, that have transportation problems, and these are all the day-to-day challenges that they face every day. And we provide the medical services for them as much as we can, given our capacity as a community health organization. But we strongly feel that there needs to be something beyond that that can help our patients. And one of the things that we really found this very attractive was to have a mobile app-based program that we can have a continuous relationship with the patients and with the Carium group and help us to really understand what is most important for our patients. Because ultimately, the most important thing is to serve the community, serve our patients, and that's what aligns our overall mission in what we are doing. And we're hoping that this will be a very successful pilot project and we can continue with this as an ongoing basis. And I'm hoping for great success with this project.
Thank you. I think I want to add one more thing as part of this conversation is, as we are talking about the fact that we have sort of identified the patient population we want to focus on, we have identified some of the staffing needs we are going to have, we have identified how many patients do you want to do. This is sort of an ongoing project for another, 6 to 1 year, because that's really when you are going to see the numbers in regards to the data of health outcomes. You're going to see the trends and the challenges and the compliance around it. So we are going to be collecting this information, and we will continue to reach out to CalHIPSO to make sure that this is sort of your first phase to the presentation that we provided today, so that we can have this ongoing conversation on how in real time with the real community health center patients and with real patients that do have diabetes and they struggle every single day in and out through our communities, how is this technology and technology in general going to help us minimize that gap and really focus on good patient outcomes?
So that concludes the presentation portion. I think we open it up for questions at this point.
Thank you all so much.
So this is David Porter with CalHIPSO again. Thank you, everyone who was part of that presentation. Mike, Dr. Chandramouli, Jaspreet. Really interesting, really innovative work that you are doing. And I will just be really excited to learn more about it as you expand your work in the weeks and months to come. We have, you guys were very efficient in your presentation, so we actually have a lot of time for Q&A. I will remind everyone who is listening to use the question box on the right side of your screen. And so far, I am not seeing anything.
Okay, so maybe if you don't mind, David, I just want to give people an idea of how Mike was talking about the platform and how we are going to actually get that, how should I say, a real-time data from the patients. So many of the people that might be on the phone, people have NextGen, they have ECW, they have Allscripts, they have Epic. And so the first level of conversation that we had with Gardner was, and as we all know, we don't want to use 100 different systems. We wanted to make sure everything directly gets into NextGen. So Gardner has NextGen as their electronic health record and their billing software. So because we are doing a cohort, we decided to actually directly use the Carium's platform, where all the communication will be coming once the patient is using the smartphone. And we have the data there where our coach is going to be available or our case manager is going to be available and accessible. The platform will be, or the portal will be accessible for them so they can directly in real time communicate with the patient. But our final goal is that once we have, we get more closure in regards to the data and the improvement and the success of this project, we want to integrate that data directly into our electronic health record. So Carium already works with some of the technology tools like ECW. Mike, can you remind me which are the other ones that there is some level of interoperability where the data can actually get into the electronic health record? I think it was Allscripts, ECW.
Yeah. We've done a number of integrations and also Athena. So fortunately the EMR vendors are increasingly making it easier to have that interoperability. So that's a big focus of ours to be able to do exactly what you just described.
Exactly. So then basically this goes back to the provider documentation and coding and then the billing part of it. So the way, the first thing, if you will talk to a CFO or a CEO, the question they will ask me is, okay, I'm doing this, am I going to get paid for it? So the conversation around it is twofold. One is, as you put this program together, you're going to do work groups, which is basically patient groups. You're going to see the patient one-on-one. It could be a provider level visit, and the patient might have other time, remote monitoring time with the case manager. So we do have information around how that reimbursement structure will work. We wanted to focus on the pilot, get started with the work, make sure we are working on any type of the kinks, either it be from a patient behavior perspective, technology perspective, case management perspective, interface that data with NextGen or the electronic health record that clients might be using, and then sort of start looking at actually the billing portion of it. That was one. This is direct remote monitoring or face-to-face visit with the provider. But also remember that as you are looking at your HEDIS measures or your contracts with different managed care or just commercial plans, there's a lot of incentive built in for your organizations on getting reimbursement based on patient outcomes. So our strategy is that first of all, if we are focusing on this 50 patients and we are actually going to see improvement, the incentives will be a direct opportunity for us to really capture that reimbursement. And then as we are doing it, we are going to integrate it into the billing portion, which is, at least for now, encounter-based billing that we as a community health center do. So I just wanted to make sure we also touch part of it, because that really goes back to the financial sustainability. So you are getting a lot of already push from your health plans, from your federal entities, for you as just a community health center, that you want to focus on patient outcomes. There's already reimbursement structure around it. There's a lot of money that comes out of the pot in regards to the QI part. And so this is the focus. For now, our focus is technology, compliance, good data, incentives, and we are ultimately going into integrating into the billing and making sure that we get the reimbursement dollars directly that way as well. And we are seeing, as you guys all know, CMS has been doing a lot of push in regards to managing the care of your patients, and remote patient monitoring is one of the codes and one of the services that they have started reimbursing. So our mind is thinking directly around reimbursement as well.
Jaspreet, I would guess that building financial models around patient engagement could be a whole separate webinar unto itself.
That is very, very true. But I think, I don't know who are the people on the phone, but, when it's QI, we are gung-ho about it. But when we are trying to get buy-in, at that time, that question always comes to the table. And I just want to make sure that that is something definitely we are simultaneously focusing on, and not just the QI piece.
Absolutely. We did have one question that came in. I think, Mike, this is directed at you. So you mentioned a couple of the systems that you integrated with, but as you probably know, even in the clinic world here in California, a lot of folks are migrating to Epic. And so we have one listener who was curious about if your integration with Epic.
We haven't yet. We've looked at that. For the particular engagements we haven't had a need to integrate with Epic, but they're very open in terms of the way they do things. They have something called an app orchard that allows for apps to have access to it. So it's certainly one that we can take on as we have an engagement that needs it.
Okay. Well, we are, a little past 12:40. Other than that one questioner, our folks are still not feeling very talkative in the chat or question box. Oh.
Okay.
And as I say that, I just encourage someone to ask a question. So the questioner says, thank you for your presentation. When do you plan to launch? Are you factoring in social determinants of health? And what metrics do you plan to measure to evaluate the program? So it sounds like 3 questions.
So we're going to be launching the recruitment of the patients is starting now. We're going to be launching in December, and the measures that we're expecting is to have both the continuous engagement of the patients. So we do a lot to look at daily active users, monthly active users, just to see how the people who have signed up are just engaging overall. So we keep those statistics, as that's important. And then obviously we'll be able to manage, to monitor how their sugar levels are performing. And then ultimately the A1C test and seeing how that improves across time. We've done a number of different engagements like this in the past where we've put together a pretty significant path for what the outcome should look like and trying to measure against that. And so we'll be doing the same thing here. And one of the great things about the sort of inherent collection of the data is that the ability to measure that progress is on a real-time basis. And so part of what we also look at is what are the interventions that can be effective? What are the ways that we can engage people as they have success and encourage that, as well as if they get off track, how to put them back on track.
Okay, great. And actually, David, just to mention, because I know we have few minutes, is the fact that we are using Gardner Health Services is using the technology focusing right now on the diabetic population, but the technology is pretty extensive. You can focus on basically any of the chronic diseases if you would like to. They are also actually, they also have the referral management part of it as well, because that's one of the key elements for at least our population when it comes to specialty care. So we just wanted to ensure that in this presentation, we specifically focus on the QI diabetes management, because there's just so much other linkage to other chronic diseases. And with our focus on HEDIS measures, as well as for, in our case scenario, focusing on HRSA, which is the Health Resource Administration, which is how community health centers are funded, because of the push from them, as well as just our internal focus on improvement, we focused on the diabetes. So we will keep the progress, we will keep the tracking of the data. We definitely will, we know our baseline information, and we'll see how this improvement is moving on the map, and continue to inform our other healthcare organizations, and continue to be very open in regards to sharing our information.
Yeah, and to add to what Jaspreet said is, you can see readily how a model like this can apply to this diabetes case. Hypertension is very closely aligned in terms of the nature of what's involved. In this case, you'd be monitoring blood pressure and measuring blood pressure, and there are connected cuffs that can handle the Bluetooth connection, all that. In a similar way, A lot of the interventions are similar. The other piece that's significant too is that this is not a condition-specific implementation. We're doing it for diabetes now, but it doesn't require that. And many patients have multiple conditions, and so the fact that you could monitor both blood sugar and blood pressure make it easy to accommodate multi-condition patients as well.
That's right.
Okay, great. And then, David, I don't know if we shared our email addresses, but I do want people to be able to email us if they have any questions, because sometimes questions come up after the webinar. So if there is an email address that they can send it to you guys, I do see info@calhipso.org, and then they can be forwarded to us. That is fine as well, but we are more than willing to share our information if people do have questions after the presentation today.
Great, and we do usually do a follow-up email after the presentation, so we can include your emails if you would like.
Yes, yeah, that should be fine. Yes.
Okay, perfect.
Great. Thank you.
All right.
All right, I'm again seeing no new questions coming in, so I will again give it going once. Going twice. So I will give everybody, we will give everybody about 10 minutes of their lunch break back. Thank you to our presenters. Thank you for everyone who hung in with us until the end. And we hope that you will look for the next CalHIPSO monthly webinar. We actually go dark in December. We find that when we do webinars in December, everyone's at office holiday parties, so we don't get any attendees, but we will pick up the series again in January. And as it says on your screen, we hope that you will circle May 7th of next year to be at the CalHIPSO conference here in Sacramento. Registration is open now. We're building a very strong agenda that we're very excited about, so we hope to see you there. Thank you very much.
Great.
Thank you very much. Thank you, David and Lauren, for doing this. Thank you, Jeffries and Mike.
Thank you.
Yes, thank you, Doc.
Thanks
Okay,
for all the
bye-bye.
attendees.
Thank you.
Goodbye.
Okay.